Dear members of the Indian Association of Cardiovascular and Thoracic Surgeons, and dear friends, I hope all of you are staying safe and well at these difficult times. I know that as a community, we cardiac surgeons never like to sit idle. Now, nature has forced an essential break in the name of COVID-19 pandemic. It is sweeping across the world and continues to take a heavy toll in terms of human lives. Chaos in the global economy and closer to home, immense suffering for the poor and the marginalized people of our country. Its global impact, sparing none, has affected politics, economic stability, and most significantly, our healthcare. Looking back at our own history, 72 years since our country's independence, for the first time, the country has entered a phase of lockdown for nearly 70 days. All of us are forced to stay indoors and have had to take difficult choices, including abstaining from carrying out our elective surgeries. What we have seen is that now the lockdown is being eased out in a phased manner across the country. A few centers have started their routines in a restricted way and have deployed their healthcare providers for COVID-19 patients. We will be entering a phase which is unprecedented, encountering a difficult subset of disease patterns. Safety of our patients, healthcare providers, and community are our highest priority. As the president of the Indian Association of Cardiothoracic Surgeons, I would like to summarize some of the issues that we need to keep in mind and offer operative practical guidance. One of my teachers used to say, when trainees ask for long leave, that if you do not operate for 2 weeks, the assistant surgeon will recognize the difference when you come back. If you do not operate for 1 month, the anesthetist will recognize. If it is more than 1 month, the staff nurse will recognize. Now it is 2 months. I fear who else will recognize. A recent online survey by one of our members regarding the impact of COVID in clinical practice has revealed that quarter of the centers did not perform surgery after the lockdown. 89% of the surgeons continue to operate elective patients during the lockdown felt that there is a drop of more than 50% of cases during this period. During the lockdown, the most common operation performed was coronary artery bypass surgery for triple vessel disease, chest pain at rest, and significant left main disease without chest pain. Apart from these, acute type A dissection and emergency aortopulmonary shunts and a few pediatric emergency procedures were performed. 40% of the centers resumed elective surgery in the second half of May, and 40% plan to resume in first half of June, while other 15% of these centers plan to reopen in July 15th. 1/10 of the surgeons had their traditional ICU transformed into a COVID-19 ICU, especially in the states where there is a high prevalence, like Delhi, Tamil Nadu, Maharashtra, and Gujarat. We found that this practice is more among the public sector hospitals. In India, none of the cardiac surgeons have operated on a COVID positive patient or used ECMO so far. 88% of the surgeons felt that the present climate will change only after 6 months to 1 year. As regards to the new daily cases and daily death, United States and Italy have reached a plateau, while it continues to rise in our country. As on May 29, India is 9th in terms of the number of COVID patients. In our country, the number of cases per 100,000 is 2.6 compared to Spain, United States, and Italy, where it is more than 300 per 100,000. Even the death rate per 100,000 is less than 0.1 as compared to those countries which range from 20 to 50. The importance of flattening the curve cannot be overemphasized. The ever-changing pattern of the disease, with no surefire treatment yet, poses a challenge to physicians everywhere. As data continues to evolve, there is still a lack of consensus on a definite guideline or protocol to treat these patients. Early reports attribute 40% mortality in COVID-19 patients to cardiovascular causes. Further, patients with pre-existing cardiovascular disease have a mortality of 11%. In a study from Germany, pulmonary embolism is the cause of death in 4 out of 12 patients. Multiple studies show that COVID-19 will cause diffuse alveolar damage with microthrombosis. I interacted with the surgeons in Europe, North America, and our Indian colleagues regarding the protocols and PPE during this period. Based on the information gathered, I thought I will share with you the following precautions while we start to perform elective surgeries. Everyone had a different protocol, which points out there is still a lack of consensus in this regard. Even with all the available investigations, the specificity and sensitivity does not reach 100%, which means we can still miss identifying potential COVID patients. Given the fluidity of the situation, it is appropriate to consider all patients positive and take necessary protection. Preoperative considerations. Try not to do very complicated cases in the beginning. It may sound theoretical given the waiting list of sick patients for the last 2 months all of us have. Patients planned for elective surgery should undergo RT-PCR 10 days prior to the procedure. If negative, they are asked to be in strict self-quarantine. A week later, they are called and RT-PCR is repeated along with CT chest. When both are negative, we can plan the surgery within 2 days' time. The idea behind this protocol is that the combined RT-PCR and CT test significantly increases the specificity and sensitivity. It is advisable to take a special consent for COVID patients to avoid medico-legal issues, especially in the present time. There should be one relative who should be staying with the patient from admission to discharge. It is preferred that the relative also undergoes RT-PCR testing. Intraoperative considerations. Restrict the team members inside the operation theater. Maintain negative pressure inside the OR. No undue opening of the OR door during the operation. Anesthetist to take all precautions during the induction of the patient. And there should be a time delay between the induction of anesthesia and the incision. Half an hour to 45 minutes to allow the droplets to settle down. PPE and N95 mask for the entire team inside the OR. Face shield is necessary. Unfortunately, we need to wear magnifying loops. Hence, do the necessary modifications and shield your face from aerosols. No guideline yet for the use of diathermy. Use them as minimum as possible. Also, there is no evidence to show difference between on-pump and off-pump CABG. If you prefer off-pump surgery, use the mist blower as minimum as possible or a fine sucker to keep the field free of blood. Take time for meticulous hemostasis. It is better to wait in the OR for a while before chest closure than to wheel the patient again for reopening. There are no special protocols for blood transfusion. You can follow whatever guidelines given in your institution. Postoperative care in the ICU. Early extubation is beneficial when patients are stable. All the ICU staff to wear appropriate PPE and take utmost care during endotracheal suction in the intensive care unit. Proper care of intercostal drainage to prevent aerosol spread of the virus and minimize the visiting hours of the relatives and make sure there is no overcrowding of the hospital staff in the ICU. During the routine ward rounds, wear the mask, face shield, and gloves, and practice social distancing as far as possible. Education of the team members. Educate all the team members, which is the responsibility of every member to adhere to the principles during this time. Encourage them not to go to public gathering till the pandemic is stabilized. The responsibility of every member of the team to adhere to the self-discipline and self-quarantine has to be emphasized. Educate the housekeeping staff about the importance of social distancing and self-discipline. In the outpatient department, maintain social distancing among every staff member. There is no I in cardiac surgery. It is always we. Cardiac surgical unit has a lot of members working in close proximity. Hence, it is the responsibility of every individual to maintain self-discipline inside and outside the hospital premises. Even if a single member is COVID positive, he or she can jeopardize the whole system, ending up in closing down of the facility. Coronavirus has infected around 548 healthcare workers, including doctors, paramedics, and nurses, according to a media report as on May 6th in our country. The antimalarial drugs, chloroquine and hydroxychloroquine, have shown some efficiency in vitro experiments. Physicians working in endemic malarial zones have good experience with these drugs. However, in non-endemic zones, hydroxychloroquine is commonly used for rheumatological disorders and for malaria prophylaxis in travelers. When a physician chooses to use hydroxychloroquine for either empirical treatment for COVID-19 or chemoprophylaxis as per government guidelines, due precautions are mandatory for the elderly, those with diabetes and cardiac problems, in whom the dosage has to be modified to avoid potential side effect of the drug. Indian Association of Cardiothoracic Surgeons has been curating and conducting an active online teaching program during these difficult times, when medical practice has arrived at a grinding halt because of the pandemic. This has paved way for virtual interaction and sharing of knowledge among all our members. I want to put on record the mammoth efforts taken by our secretary, Dr. Hiramath, and his technical team led by Aditya in coordinating and conducting these lectures even in the odd hours. But for his untiring efforts, this great exchange of knowledge would not have taken place. I would like to thank Dr. Krishna Iyer, our Senior Vice President and Chairman, Scientific Committee, and all the executive members for their individual contribution during this difficult time. As of today, 156 webinars were conducted across the spheres of cardiovascular and thoracic surgery and its subspecialties. Adult cardiac 75, congenital 40, and thoracic 41. We had also arranged the live webinar of the AATS this year. 3 mini symposia were organized on minimal access surgery, lung and heart-lung transplant, and the ongoing series on cardiac morphology with Professor Robert H. Anderson. The attendees included surgeons from more than 24 countries. Over 52,000 viewership is there till date in these webinars. The 86 distinguished speakers included senior national faculties and eminent international faculties. On behalf of the Indian Association of Cardiothoracic Surgeons, I would like to thank all the national and international speakers for being part of this educative program. We are in the process of acquiring CME credits for these master classes. On June 8th and 9th, we have arranged live transmission of Ancona virtual live course presented by CTSNet on minimally invasive and transcatheter cardiac surgery from theory to practice. The conduct of midterm CME and the Techno College CME will be decided shortly after discussion in the executive committee. We are trying to create a portal in the Indian Association of Cardiothoracic Surgeons official website dedicated to COVID-19 soon, in which you can share your clinical experience during this pandemic. This will be of immense use to all the other members. Please share with us your hospital experience in dealing with this crisis to the president at iscts.org or secretary@iscts.org or the official website of the Indian Association of Cardiothoracic Surgeons. COVID-19 has taught us how data collection remains an important pillar for the healthcare system. Keeping that in mind, as a first step to data mining, Indian Association of Cardiothoracic Surgeons is conducting a survey of the number of cardiac surgical centers and patients operated in our country. All of you must have received a mail from the Secretary's desk in this regard. This will be the first step towards developing a database and registry like the STS database or the IRAD, paving way for more scientific research and publication from our country. It is my humble request to all the heads of the units to take the lead and involve your junior colleagues in collecting the data and filling in the form. And please submit to the association at your earliest convenience. The aftermath of this pandemic on the healthcare is yet to know. As we all continue to work together amidst the challenges, please stay in touch and share your knowledge. Learning from each other, we will continue to serve our surgical fraternity, our members, our patients, and our community as a whole. Together, we can tackle this historic public health crisis. Stay safe, stay healthy, and please take care. Thank you. Jai Hind.